Outcomes for patients with NMDA receptor encephalitis have not changed over the last decade. We need your help to refer newly diagnosed NMDA receptor encephalitis patients who may be eligible to participate in the NIH-sponsored Extinguish trial. The Extinguish trial is now enrolling new NMDA receptor encephalitis patients. To learn more, search Extinguish trial at clinicaltrials.gov or call the Extinguish hotline at 844-4BRAIN-5.
This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, and welcome to the Neurology podcast. This is Dan Ackerman from St. Luke's Health Network, and today I have the pleasure of speaking with Thanh Nguyen from Boston University about her paper titled Dual Antiplatelet Therapy versus Alteplase for Patients with Minor Non-Disabling Acute Ischemic Stroke, the Ackerman randomized clinical trial. Thanh, thank you so much for joining us on the podcast today.
Dan, thank you so much for having me. And I also want to acknowledge the principal investigator of the trial, who is Huixing Chen. He was the brainchild behind this Ackerman trial.
Wonderful. Well, thank you, Dr. Chen, as well, because this is a great study. Now, there are so many important things in this paper for us to unpack, but one thing I just want to get off the bat, this idea of minor non-disabling stroke. Could you just talk to us a little bit about how you defined minor non-disabling stroke, and how does this affect your clinical practice from day to day?
So minor non-disabling stroke was defined in the Ackerman trial as patients who presented with acute ischemic stroke with an NIH stroke scale of 5 or less, and they had to have 1 point or less on the NIH single item scores such as motor, vision, language, neglect. And you couldn't score in the consciousness item because we were worried that would be a potential stroke mimic or a patient with encephalopathy. So that was excluded. And then the study treatment had to start within 4.5 hours. So if these patients met these criteria, they were automatically considered for the trial. And then in terms of the non-disabling component, that was a little bit trickier because we had to ask the patient or their family, if the patient wasn't able, we had to ask them to what degree would this deficit that they present with might interfere with their activities of daily living, their hobbies, or their work. And so that was a very important component of selecting if patients would be eligible for this trial, because as you know, this is a very controversial population for consideration of Alteplase versus other therapies.
Absolutely. I think in our practice from day to day, it's very easy to be pigeonholed a little bit by the NIH stroke scale. And the NIH stroke scale is wonderful as a tool, but recognizing that patients who score 0 on the stroke scale may still be symptomatic, and those symptoms could still have a major impact on their life. Having a method like this to pick out those patients for whom the symptoms would still be disabling in their eyes, and having that open communication about how important the symptoms are to the patient does a great job of really reinforcing that early doctor-patient relationship, since we're trying to deal with this rapid decision-making, and helps us to orient ourselves in terms of Alteplase versus other potential therapies. I love that.
And to ride on your point, Dan, even though you could be included with an NIHS of 1 point on the motor scale, so say you had a drift, if that was going to be potentially disabling to the patient, meaning, I need to play violin or I need to play my piano, then they probably would not have been included in the trial.
Now, in this trial, this was a non-inferiority study comparing Alteplase versus dual antiplatelet therapy. So tell us about the results. What did the trial teach us?
It pivots on the point that the NINDS trial, the initial trial that demonstrated that TPA was effective in patients presenting within 3 hours, they were excluding patients with rapidly improving or minor strokes. And so this set the bar for who you should treat with TPA or not. And then in 2011, we saw some data coming out from Get With the Guidelines. There was a paper I remember as a resident, Eric Smith and Lee Schwam, looking at these patients with rapidly improving minor strokes, and a significant proportion of them had pretty poor discharges. They didn't do well on discharge criteria from Get With the Guidelines. And so this spurred some interest in looking at these patients in more detail. So we fast forward to the IST trial, the International Stroke Trial, where they compared Alteplase versus routine medical management in patients with all kinds of stroke. And then they focused specifically on patients with minor stroke, so NI stroke scale 5 or less. And so Dr. Khatri performed this very nice analysis. And what she found was that in these subgroup of patients where they had minor stroke defined as NIHSS of 5 or less, there seemed to be a treatment benefit of giving Alteplase by approximately 9% absolute benefit of getting better outcomes, better excellent outcomes, which in their study was defined by the Oxford Handicap Scale. So they took that equivalent as like the MRS 0 to 1. And some guidelines building on these early data were stating that you could consider giving Alteplase to patients with minor non-disabling strokes. So the early 2018, I believe, AHA guidelines, and then the Chinese guidelines also said that it can be considered. It wasn't a strong recommendation, however, but it was in the guidelines. So in our psyche, when we're seeing these patients in the ER, we're always asking, when was your last known well and what are your deficits? And so even these patients with minor symptoms, they were being considered for Alteplase. So that's why we wanted to see, well, can we compare these patients with dual antiplatelet? And this idea of dual antiplatelet really emerged, as you know, from the POINT and the CHANCE trials, both trials showing that DAPT was better than aspirin alone in these patients with minor ischemic stroke / TIA in reducing the recurrent event rate. So Dr. Chen and colleagues wanted to study this by a non-inferiority design. Well, maybe the dual antiplatelets are not inferior to Alteplase, and then we can prove that it's good enough to give these patients DAPT if it was true. And so the findings in this study were that indeed, after enrollment of, I think, 700 patients, we found that dual antiplatelet therapy in these patients was non-inferior to Alteplase, and we met the non-inferior border margin on the confidence intervals. And so we exceeded that. And so that's why, in essence, this was a positive study showing that patients overall did quite all right with dual antiplatelet therapy compared to intravenous Alteplase if they presented within 4.5 hours. And in terms of the proportions, there were about 93% who had MRS 0 to 1 in the DAPT group, and 91% had MRS 0 to 1 excellent outcomes in the Alteplase group. So pretty strong data to show that DAPT is non-inferior. And we weren't seeking a superiority signal. So even though the number was higher in DAPT, I don't think we can say it being superior.
Thank you so much for that background. That's outstanding. It's a real masterclass in reminding us how we got to where we are in current treatment. Okay, so based on this study, we're suggesting that dual antiplatelet therapy with aspirin and clopidogrel is non-inferior to systemic thrombolysis with IV Alteplase according to the standard protocol at 0.9 milligrams per kilo, maxing at 90 milligrams. That's right?
Again, this was a study conducted purely in China, so of course, the question of how transportable are these data outside of China is another big question. And obviously, we can look at the parallels with the CHANCE trial, which came out earlier than the POINT trial. So these were the dual antiplatelet trials. And when CHANCE came out showing that DAPT was superior to single aspirin, then the world was waiting for POINT, meaning they said, we're not going to change our practice because this was in a Chinese population. So let's see what POINT shows. And indeed, POINT showed a very similar pattern. And so the fact that there are some similarities in outcomes between CHANCE and POINT, I think you can potentially speculate that that might be the case for these patients between DAPT and intravenous Alteplase. So it's a speculation. It's not hard evidence, but in short of that, it is some evidence that could give you some reassurance as you're making these decisions, seeing these patients in the ER.
Yeah, I really couldn't agree more. I remember when CHANCE came out and sort of waiting for POINT, and then later on we saw THALES coming out. And the fact that those populations are really quite similar to the population in this study would suggest that maybe those concerns over generalizability are not as significant as we originally might have thought them to be. We'll have to see as the data continues to mature, but I think it's a really great point that you made. And speaking of CHANCE and POINT, there was some variability in a post-CHANCE and POINT world with regard to the dual antiplatelet therapy that's chosen. In particular, do you load with 300 versus 600 milligrams of clopidogrel and typically maintaining that for 3 weeks. In this study, the choice was to load with 300 milligrams of clopidogrel in addition to aspirin and to maintain that combination for 2 weeks. Why was it organized that way?
This was drawn from the previous data from Chance and Point, obviously. Chance loaded with 300 milligrams and then continued dual antiplatelet versus aspirin for 21 days. And then Point loaded with 600 milligrams. So they went more aggressive on the treatment up front and then went with, I believe it was 3 months of dual antiplatelet versus aspirin. And so in Chance, what we noticed is there was no increase in hemorrhage rates between the dual antiplatelet versus the aspirin group, whereas in Point, there were excess hemorrhages in the DAPT group, not necessarily ascribable to the 600 load, but that's what was observed. And so because there's this signal of potentially higher hemorrhagic risk with this regimen, then we just wanted to keep with the bare minimum, going with the 300 milligram load. And the question is, why would you go with a 600? And the potential answer is because when you go with 600, you get to a therapeutic level faster to being therapeutic on the antiplatelet regimen, but maybe 300 is good enough. So that's why in Aramis, we went with 300. With regards to the question about duration, in the Chance study, they looked at the duration. Do we really need to go out to the 21 days that Chance went out to? And so they did a sub-study in Neurology, and they looked at this, and they found that the turning point was about 10 days, after which the risk-benefit ratio between dual antiplatelet versus single antiplatelet converged. And so that's why in Aramis, we did not want to increase the risk of hemorrhagic events. We wanted to maximize the potential effect of dual antiplatelet. And so we limited this to the 2-week regimen based on that sub-study of the Chance trial.
I really appreciate that insight into the thinking as the trial was being designed. And I think that kind of information is really helpful for how to apply these study results to patients that we're seeing today. With this particular study, did you notice any challenges in the safety arm in comparing the bleed rates of systemic Alteplase versus dual antiplatelet therapy?
That's always the greatest concern, is bleeding. That weighs heavily on us every time we give drugs to these patients. And so in terms of symptomatic hemorrhage, which is what we are most concerned about, between Alteplase and dual antiplatelet, there was essentially no difference, although numerically there were more event rates in the Alteplase arm, so 0.9% of patients had a hemorrhagic event that was symptomatic compared to 0.3%, but still that's not significant. And if you look at any bleeding events, then this was significantly higher actually in the Alteplase group, 5%, compared to the dual antiplatelet, which was 1.6%. So that was significantly different in terms of any bleeding events, but for what we were always worried about, the symptomatic hemorrhages, it wasn't different.
Thank you for that. So a little bit as we might expect, there was some excess bleeding in the Alteplase group, but not symptomatic hemorrhage. Now, anytime we're talking about acute ischemic stroke, it's important that we remember that there are going to be some patients with stroke mimics in our treatment groups. That's just the nature of the beast. And they say if you have never treated someone with a stroke mimic, you're just not treating enough stroke patients. Do you think that these results inform our treatment of patients, particularly those with stroke mimics, in any particular way? And how was this dealt with in the study, if at all?
Every day we're always wondering, are we treating a mimic, right? Because we're not getting MRI routinely on these patients because there is no time. So really your decision to treat is based on the clinical presentation, the history, and the exam. And so inevitably you will be treating mimics, and I certainly have in my practice. As for Aramis, they included patients based on the clinical presentation, and also there was an imaging criteria of demonstrating ischemic stroke on CT or MRI. And so to what degree patients had either modality, I would have to dissect in the details of the protocol. But suffice to say that in real world, you're not necessarily going to know if you're going to be treating a mimic up front unless it's obvious and they have other medical history, like a prior migraine that's complex. So you may not know that up front. In Aramis, unfortunately, we didn't have a special section for the mimic patients because most of the patients were already confirmed by imaging. When you look at the consort diagram, there were 2 patients that were excluded by the fact that there was no stroke on MRI. So I think this was a very refined population of hard stroke, meaning imaging confirmed stroke. So unfortunately, that was not well addressed in the Aramis trial. Suffice to say, even though it wasn't addressed, what you can think is if you have a potential mimic that exactly meets or mirrors the criteria of Aramis, you might feel reassured that, okay, well, I may not want to go aggressive and give Alteplase because of the bleeding risk. But if I give DAPT, I may not be harming the patient either or taking away a potential benefit of giving them TPA. So you might have some reassurance based on that Aramis trial.
Very reasonable. In particular, sometimes the more so-called minor or less disabling stroke cases are the ones where we're more concerned about mimics. Patients who present with a severe clear stroke syndrome that localizes very well to one area of the brain most often are indeed experiencing a stroke. But at times when we have a little more of that wiggle room in patients who have more mild symptoms that we could attribute to multiple potential causes, well, that's where the mimic population is really centered. So I really appreciated your explanation. I also really liked the secondary endpoints and the subpopulations in this study. And in particular, those patients who presented to the clinical trial group with minor stroke or minor non-disabling stroke, but also large vessel occlusion. Could you comment a little on how that group did in particular and any other subgroups that you feel were particularly important to bring out?
Yes, that was actually a reviewer question, which is great because it's naturally the question that everyone wants to know. So we had to further delve into the data and look at patients who had the data on large artery occlusion. And as you can imagine, because the entry point of these patients are patients with minor stroke, they're not obliged to undergo CTA from the outset in clinical practice because guidelines say you don't have to treat patients less than NIH of 6. So naturally, because of that, we don't have a lot of data represented on the presence of large artery occlusion. I think it was only present in 36 of the 700 patients in the study. And so this is largely underrepresented. And when you look at the confidence intervals, I don't think we can say very much as to whether Alteplase or DAPT is better, but that we need more data. And fortunately, there will be data that's already being studied by the Calgary group. Dr. Sheila Coutts is looking at this via an international trial with Tempo, looking at thrombolysis for these patients with minor stroke and large vessel occlusion. So I think we'll learn a lot more there.
As some of the advanced vascular imaging continues to come into the mainstream, and certainly at many hospitals, that becomes part of that initial stroke evaluation, it's going to be a really important question to continue to address and consider for patients who have minor symptoms, but evidence that they may be at higher risk for worsening compared to your average patient with minor symptoms that does not have a large vessel occlusion. But really, that gets down into the nitty-gritty of some very specific patient situations. Thanh, this study was done in China, but of course, stroke is a worldwide problem, and there are huge differences from one country to another with regard to healthcare organization, healthcare resources, and particularly in low and middle income countries, there can be a major impact on someone's care with regard to the cost of treatment. Could you speak a little bit about how this study could be useful in different settings and some of the feedback that you've gotten from people around the world with regard to these results?
What I didn't realize when we released this paper was the reaction from colleagues in lower or middle income countries where they welcomed this study because of the potential ramifications for patients in terms of cost of treatment, where in some countries, patients do have to pay for Alteplase, and it can be a significant cost to them versus aspirin and clopidogrel, which might be a lot lower cost compared to the intravenous lytic. So in patients where you have that potential controversy or that equipoise where they might meet the Aramis criteria, giving them dual antiplatelet would offer some reassurance that this is a okay treatment to offer these patients, and you're not offering inferior treatment than Alteplase because they're presenting with stroke-like symptoms, and that the families could rest assured and the patients could rest assured that the outcomes are likely going to be excellent, whether or not you go on DAPT or on intravenous Alteplase, kind of attenuating the intensity of resources of the cost of the drug and the aftercare of these patients in the first 24 hours in an intensive care unit setting or a step-down unit.
When we talk about cost to the patient and to their family, as well as the cost to healthcare in general. It can be much higher with Alteplase versus aspirin plus clopidogrel in all sorts of different settings. And because acute ischemic stroke is such a time-sensitive, crucial emergency, it can be very easy to be a little bit more blind to those costs compared to the average neurologist treating patients in other kinds of settings. So keeping that in mind, and particularly recognizing the difference from country to country, is just really crucial. I think overall, this is a very elegantly done study, and it's really going to help inform our treatment and really is a great next step after Chance and Point and Thales to help us understand the best way to treat patients with minor stroke and minor non-disabling stroke. Anything else that you wanted to bring out and summarize about the study?
Yeah, I just wanted to draw out the fact that when you look at the NIH tiers, grading from 0 to 1 to 3 and 4 to 5 subgroups, there was a bit of a signal for the patients with NIH of 4 or 5, seeing potentially a signal for Alteplase being better than dual antiplatelet. So I just wanted to mention caution for these patients where they accumulate NIH points because they may not be as disabling as we think. And so I think this is obviously a moving target and a population we just want to be careful about before we apply our criteria too liberally.
I think this study really helps to drive home the point that it's not a one-size-fits-all kind of approach to stroke care, and that we need to be able to take this data and apply it to each patient as an individual and make sure we understand the stroke symptoms they're experiencing in the context of their lifestyle and what are the potential risks, benefits, and alternatives to systemic thrombolysis in that setting. I really think that this was exceptionally well done. Thank you so much again for talking with us today. Again, we've been discussing the paper titled Dual Antiplatelet Therapy versus Alteplase for patients with minor non-disabling acute ischemic stroke, the ARAMIS randomized clinical trial, which appeared in the June 2023 issue of JAMA. Thanks so much again.
Thank you, Dan.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.